much. The next speaker is Dr. Gopal Arora. He was the president of the Maharashtra Ophthalmological Society, and he's also a member of the AIOC committee, managing committee, and he is a high-volume phaco surgeon. He will be speaking on non-visco phaco emulsification, and he's demonstrated this technique in live surgeries at BOA very often, sir. Dr. Gopal Arora.
Thank you, Dr. Ragini ma'am, first of all, for making me a part of this interesting IC. First of all, I would like to say that no visco phaco has come as an accident to me. As it has been said, that necessity is the father of invention. That is what happened to me when I had gone to a peripheral center operating lot many cases, and in the last 2 cases when I asked for the viscoelastic, they said the visco is over, it will take out more than an hour or 2 to get the viscoelastic. So I thought, let's proceed without using the viscoelastic. And that is how this thing came to my mind. Then I retrospectively actually studied that where actually we need viscoelastics. So even before the invention of viscoelastic, cataract surgery was done. So the capsulotomy or other things were done under that air bubble. But the problem was that if you're putting an IOL without a viscoelastic, you're bound to rupture the posterior capsule, which used to happen. And secondly, if you are rubbing it on the endothelium, then endothelial decompensation was a part of the surgery if you're not using viscoelastics. So basically, viscoelastic came as a replacement for the air bubble used to do capsulotomy and lens insertion during the surgical complications, which were the ruptured capsule and the decompensation. Basically, the use of viscoelastic is to create space for doing capsulotomy and to balance the pressure between the anterior and the posterior segment, and to stabilize the tissue, and of course to protect the endothelium. To form the anterior chamber before the IOL insertion, again, is the area where viscoelastics come into picture. And few surgeons use viscoelastics over the cornea to to enhance the visualization during surgery, but that is a relative distant indication. But are viscoelastic totally free of complications? Because we have seen the hike in the intraocular pressure may be very transient because of the mechanical blockage by trabecular network or the antigen-antibody reaction due to trabeculitis. Capsular block syndrome and the distension syndrome leading to pseudomyopia, though transient, again is a possibility. Inflammation, we have seen a lot of infection end of cases, and this visco being the culprit. And of course, we need copious washing. Since we have put viscoelastic, we need to remove it. So what is modern day cataract surgery all about? It's a closed chamber, the smallest incision, the best fluidics, efficient power delivery, and least intraocular trauma, and of course what you are doing should also be reproducible. So phacoemulsification without the use of viscoelastic, of course, is a possibility. What are the advantages? It's a faster surgical time, less risk of post-op IOP spikes, and of course the biggest advantage to me was the continuous irrigation that you are putting from the left hand maintains the chamber stability, it protects the endothelium, fixation of the eye, because I use irrigating cannula like the irrigating one cannula from the left hand side, it helps me fix the eye as well. And of course in toric IOLs, since there are 3 steps in toric IOLs, the last step is actually making the final alignment after you remove the viscoelastic. So that step can be totally eliminated because you're not putting the viscoelastic. Post-operative data shows no significant difference between the 2 groups in endothelial cell loss. So phaco without the use of viscoelastic is safe and effective. But there are few reservations. If it's a very hard cataract with a compromised cornea, one should avoid. If it's a high hypermetroph with a shallow anterior chamber, again one should. Intumescent cataract, we know that the rexes give way. Small pupils, because we might have to use the iris hooks. Pediatric cataract, for simple reason, we aim at a 3 mm rexis and it gets converted into 6 mm. And if there are complications like the PC rent or IOL exchange because of the broken haptics, you need to use viscoelastic. But those contribute to not less than 15 to 20% of your cases. This is just a video I would like to show you about how we can go ahead by doing a phacoemulsification without using a viscoelastics. Normally, these days I make a left side port first with an MVR blade. Yeah, I'm making it with the right side. So normally you make a 2 side port with the MVR or lance tip blade, whichever you're comfortable doing with. And after you have done these 2 side port, the first thing that you need to do is that maintain the chamber by putting one irrigating cannula from the left hand side. As I told you, it serves two purposes. One is it maintains the anterior chamber, it fills the anterior chamber. Second, you can hold the eye with the left hand because it's done under topical anesthesia. In any case, whether you are adopting this no visco technique or not, but you can actually hold the eye with the left hand throughout your procedure. In a topical case, this helps wonderfully. The trick here in doing a capsulotomy is that you need to just change the direction of your irrigation so that the rhexis flap is everted. So just this irrigating cannula directing the fluid towards the capsulotomy should be the main aim of directing the anterior capsular rim. Again, it should be everted. Now you just need to do hydrodissection from the side, and with the Sinskey hook you need to separate the nucleus from the epinucleus so that the nucleus is free. Now is the area where again you would require viscoelastic because you're taking out the instrument. So you just hydrate the two side ports so that the anterior chamber is again formed and filled. Now once you have done this, before you actually put in the phaco probe, you need to put the irrigation on. Never the phaco probe should enter with the irrigation off. So with the irrigation on, you can put in your phaco probe, and now it is just like any other phaco emulsification procedure, whether it's a direct chop or stop and chop. That's the technique of your choice which you want to adopt, as have been emphasized by the previous surgeons. So that is an individual choice, and you can do the phaco emulsification from what best works in your hand. Now after the nucleus is removed, as you can see, the chamber is already formed. Now there is hardly any role of filling the anterior chamber with viscoelastic because the chamber is already deep. So once you have removed the main crux of the nucleus, then you do the irrigation aspiration. I am more comfortable doing it with the irrigation aspiration cannula because I remove the cortex from one end. At the same time, I do the polishing of the undersurface of the capsule. I just change my hands and remove the cortex on the other side, and I do the polishing of the undersurface of the anterior capsule from the same side. Now again, you just need to slightly hydrate the side port so that the chamber is formed. Now believe me, this is something I have been doing throughout my life. I mean, hydroimplantation of the lens is something that everyone should adopt from tomorrow because it works in everybody's case. It's just a matter of practice for 5 to 10 cases. You just need to put the BSS or saline, whatever you're using, from every end of that cartridge. Over the cartridge, from this side port, from this port in the cartridge, again you can fill it from the other end of the cartridge. So fill in as much as BSS because the moment you put in, it's going to leak. So, but you try to fill it as much as you can, and then try to do the hydro implantation of the lens, which I call, and it's a very easy way of doing it, whether it's a hydrophilic or the hydrophobic lens. And as you can see, again, the left hand works wonder in fixing the eye. The patient cannot move his eye because I have fixed it with the irrigating cannula, and I put the lens, and it is under the irrigating fluid. And I just dial it with a Sinskey hook. The lens goes in the bag, and it fits in very well. Now what you need to do is just remove whatever debris you can because here there's no viscoelastic, nothing more to be removed. You can just hydrate the two side ports and the main incision if you wish to, and the surgery is completed. So to summarize, there is less post-op intraocular pressure spikes, surgical time is fast, fixation of the eye to me is the biggest advantage. At least you eliminate one area which is going to cause some contamination. And this is my favorite slide, which Einstein, I really am awe of this slide. So thank you so much for the patient hearing.
Gopal, thank you very much. I think it was a very nice presentation. And no visco lens, that is normally I do in the ICL. It means when I am doing for the this phakic IOL, I am using that. But you can use some visco. If not, you can without visco also. That is good. So thank you. Come.